Welcome to this edition of Modern Aesthetics Journal Club. I'm Rebecca Kazin, here today with Dr. Buford talking about revisionary breast procedures. Thanks for coming.
Thanks for having me.
So tell us a little bit about the patients that are having these revisions done and who's doing the revisions.
Over the last 5 years, my practice has added a significant amount of growth with respect to revisionary breast surgery. The type of patients I'm seeing are anywhere from 25 to 55 years old. Obviously, they're all women. These are patients that have had previous breast surgery and for some reason, whether it's the aging process, having had kids after the surgery, or simply that they never got the result they wanted, are coming in to have their results revised.
Who do you think is best qualified to be doing the revisions?
Good question. Tough procedure. This is probably one of the more challenging procedures in all of plastic surgery. And so leaving this up to someone that has only done a few of them is really not a good idea. I can tell you that the majority of the procedures that I do, there's no information in the literature with respect to how to fix these problems. This is something that you think out of the box. This is the type of procedure, it's actually a compendium of procedures that I've essentially learned how to do over the years. And I've been doing this for over 14 years. So wide range of patients, but overall, once they have the surgery, very happy patient population.
That's great. And so what percentage is it the aging process versus not happy with the outcome?
You know, it really varies. I think probably a good percentage, probably maybe 35–40%, are having changes related to the aging process, whether it's droop, which we call ptosis, whether it's capsular contracture, which is the number one complication seen worldwide with breast surgery. But over the years, as more and more unqualified surgeons and some non-surgeons, unfortunately, are performing breast surgery, we are seeing results that are disastrous, literally disastrous. Results where the implants are bottomed out, the lower pole is stretched, they may meet in the center, a number of results that are just simply not acceptable.
Is it more common to need a revision if the implant is over the muscle versus under the muscle, saline versus silicone?
You know, I don't know that there's any really good studies looking at that. In terms of changing from saline to silicone, nearly almost all my patients go from saline to silicone. I've never had a patient go to silicone and want to go back to saline, simply because the silicone implants move, they look, they feel more natural than saline. Regardless of the placement of the implant, we're not necessarily seeing more complications related to the placement of the implant above the muscle, but a lot of patients that have the implants above the muscle do opt to have them replaced under the muscle over time. It simply gives them a more natural result.
What about the entry point for the insertion of the implant, whether it's around the areola or underneath or through the axilla? Which way are you doing it?
You really can't revise a surgery through the axillary approach, okay. And that's one aspect, one shortcoming of the axillary approach. I used to do actually a lot of placement of saline implants through the transaxillary incision. I no longer do that. The periareolar incision, there's a higher incidence of capsular contracture long term. I prefer approaching through the fold position, especially if I'm adjusting the fold itself. I simply go underneath that incision and I'm making adjustments, and you're right there. Anatomically, it makes more sense.
So people that are getting the revision because of aging and ptosis, do you do a breast lift or do you put a larger implant in?
Another great question. If you left it to the patients, most of them would have me place a larger implant. That doesn't make any sense at all. And the reason being, you can upsize slightly, but if you think about it, the reason a breast droops is because of the fact that the tissue actually expands and the fibers called Cooper's ligaments actually stretch over time. So if you think about it, if you have something that's attenuated, that's stretched out, now you suddenly place a larger implant that weighs more. Guess what? Gravity is not your friend. So suddenly now you're taking attenuated tissue, stretching it out even more, and meanwhile, over the first 6 months, 12 months, 18 months, what have you, your result then falls. So what I do is I may upsize slightly, but very conservatively, but I combine that usually with a lift.
So what do you tell patients to try to avoid needing a revision?
Don't have breast surgery. There's, in terms of, there's no real way to avoid the need for breast revision. Complications, untoward results can happen with the best surgeons. I mean, let's face it, any surgeon that tells you that they've never had a complication, that every single one of their breast surgeries has turned out perfect, is simply not being truthful. But what I would say is to minimize the risk for complications, number one, choose your surgeon wisely first. Know what their background is, know their experience. Choose a board-certified plastic surgeon that's not only board-certified in plastic surgery, but that's also focused specifically in breast surgery as itself. Second, avoid very large implants. Large implants tend to stretch tissue, and there's really no way of going back. Once the tissue is stretched, it won't come back. So I generally recommend that my patients use fairly conservative implants, not as ridiculously conservative as some recommend, but I do recommend somewhat of a conservative approach.
How do you know if your surgeon is focused in breast surgery? You ask them how many they've done, but you might not know what a reasonable number is.
Yeah, I would say ask them how many they do on a yearly basis. First of all, look for certification. Look at the American Board of Plastic Surgery. Make sure they're board certified. That's first and foremost. How many years have they been in practice? Now, that's not saying that a young physician that's been out a few years. I've been out 14 years, still consider myself young. But someone that's been out a few years may actually have very up-to-date techniques. But the bottom line is they haven't been in the trenches as long. They haven't gone through as many of the difficult cases. They haven't attained the gray hair status that I have, unfortunately, good or bad. But you need to have someone that's performed probably a good 1,000 breast surgeries. And that's a fair amount. I've performed over probably 4,000 or 5,000.
Okay. What's the typical time to revision?
It really depends. It really depends on why you're revising the surgery. If it's the aging process, a lot of women, now that's changing actually. We used to see a lot younger patients in their 20s or early 30s. I recently operated on a patient that's 69 years old. So it's really changing. Denver and Colorado in general too is a very, very different community. So we're seeing we're seeing a changing age of the patients. But for the aging process, usually most of these patients, we're seeing them getting revised probably in their 50s or 60s. We're also seeing patients that have developed bad results with respect to over-dissection. They may have been over-dissected medially where the implants actually touch. It's called somastia or bread loafing on the internet. We've had patients where they've bottomed out where one's fallen. We've had patients where they've laterally fallen out as well too. So those patients, we usually see those patients a few years after their surgery.
Interesting. All right, well, this has been really interesting. Thank you so much for joining us.
Well, thank you for having me.
And thank you for joining us, and we'll see you again at our next episode.